of the burden that we have and the burden that we have as Africa, and to be able to share with you the various strategies that Africa is taking up and to give you a background as well. So we are going to start this discussion, and we hope to have as many questions. Please be aware that we have people as well online that will be able to join us and will be able to get some questions as well. But before we have all those questions, we're going to have the various panelists be able to give us different perspectives. We have country experiences of countries that have been able to implement. We have partner experiences that will be able to tell us what has been happening. So to start this discussion today, we're going to have, like I said, cervical cancer is preventable, treatable. Prevention can be through HPV vaccination. So HPV vaccination, we have vaccines that are available in the market. And we have seen lately that countries like Australia that have been vaccinating for some time have seen 70% drop in HPV infections for girls or women under the age of 20. So we know that the vaccines work. And to be able to give us an overview of HPV vaccination on the African continent, I'm going to invite my colleague from the World Health Organization, Dr. Fiona Atuhedwe, to be able to give us an overview of HPV vaccination on the African continent.
Thank you very much, Dr. Kapambwe. So I'll just give you a background of how far we have come with HPV vaccination on the African continent. The very first, how we started the program on the African continent was through what we call demonstration programs. These were programs that were 2-year programs because the HPV vaccine is given to a unique age group that we do not normally vaccinate in our immunization programs. Normally we vaccinate children who are below 1 year or children who are below 24 months, but now we were bringing in adolescent vaccination. So we did not want to go wrong. We wanted to see, can countries actually vaccinate girls in this age group? And if they cannot vaccinate, in the 2 years, we are trying to learn how do we get these girls? Do we get them in school? Do we get them out of school? And if they're in school, how do we get to them? And if they're out of school, how do we get to them? So we had 27 demonstration programs. These were in 27 different countries between the years 2008 up to 2017. And 2018 is when we saw our last demonstration program, which happened in Sao Tome and Principe, an island on the western coast. So in 2011, we had the first African country, which was Rwanda, introduced the HPV vaccine nationally to girls in their country. And in 2015, we started seeing other countries come in, like Uganda, like Botswana, like South Africa introduced in 2014. Then continuously, we've seen countries increase to vaccinate girls nationally. So far, we have 14 African countries, including Ethiopia. Ethiopia introduced HPV vaccine to girls aged 14 last year in December, and they're continuously vaccinating those girls. The World Health Organization has recommendations. After review of data and evidence, we came up with what we call the WHO position paper on HPV. This is data that has been reviewed by experts and scientific experts, people who studied the vaccine, people who have introduced the vaccine, and they come up with recommendations to countries. So as WHO, we recommend that the HPV vaccine is given to girls aged 9 to 14 years of age. Like Dr. Kapambwe mentioned, HPV is one of is the most common sexually transmitted illness, and this is because it's sexually transmitted. How vaccines work, we want to get to the client or to the patient or the individual before you get the disease. That is why we give polio vaccine at birth, because we don't want the child to get in touch with it. That's why you get tetanus vaccination at birth, so that the person doesn't get the disease. Once you've gotten the disease, there's no reason to vaccinate you. So the reason we vaccinate 9 to 14 is because we believe that these girls have not yet had sexual intercourse to get in touch with the HPV vaccine. So the WHO recommendation is 9 to 14. It is a 2-dose vaccine, which is given with a minimum interval of 6 months apart. So the girl gets the first dose, Then after 6 months, gets the second dose. But for girls that are HIV positive, and like Dr. Kapambwe mentioned, people who are HIV positive are at a higher risk of developing cervical cancer. So for these ones, we give them 3 doses because we want to increase protection for them. And girls are also aged above 15, we give them 3 doses because of the high likelihood that they could have either encountered the HPV virus or because of the way the vaccine works beyond the age of 14. So over back to you. Just to mention to you that generally high-income countries, we have 84% of girls in the high-income countries that are of countries that have introduced the HPV vaccine. 34% of middle-income countries have introduced HPV vaccine, and just 12% of low-income countries where the highest burden of this cervical cancer is have introduced this vaccine. Just 12% of countries bearing 80% of the burden have introduced this vaccine. So we encourage all countries in the African region, especially sub-Saharan Africa, to introduce the HPV vaccine because it's the first level of prevention of cervical cancer. Then we combine it with cervical cancer screening and early diagnosis and treatment, just like Dr. Kapambwe said. Over to you.
Thank you so much. So I know that we are talking to people, some online from different countries, but we have people in the room who are the media from within our continent. And I think one takeaway message, as you can hear from what Dr. Fiona has been talking about, is that while we are bearing the highest brunt of this disease, we are the continent that has least started these vaccination programs. So one of the things that we want to discuss with you is to talk about the efficacy, the safety, and the effectiveness of this vaccine. And to do that, we're going to have Dr. Nelly Mogo coming in from Kenya, who has done research, who's a reproductive health specialist as well, a renowned researcher, to give us a briefing on the efficacy, the safety of the vaccine that we're talking about, which is HPV vaccine. Dr. Mogo.
Thank you. Good evening again. As a reproductive health specialist who sat in wards in my country in Kenya, watching women coming in with cervical cancer, dying from cervical cancer, and experiencing the pain of cervical cancer, when the results of the effectiveness and efficacy of the HPV vaccine came out, I was extremely excited. But that was a long time ago. That was 2006. Look where we are. And this vaccine is still not with our girls, it's still not with our women. So just to get back on what that data was, there were 2 large trials done primarily for what is known as proof of concept. And they were labeled Patricia and Futures trial. They were done mostly in Europe. And they looked at giving 3 doses to girls ages 15 to 26. And the question they asked is, how well does this vaccine work to protect the recipient from acquiring this HPV HPV infection in the vaccine, and how well does it work from protecting this woman from the changes on the cervix that occur because of the HPV virus. And the news were extremely exciting. It's actually one of the most effective vaccines. It has an efficacy level of over 90%. Just to reiterate, we're all familiar with the other vaccines, like measles vaccine. Measles is about 86%, but we know that we don't see measles anymore. Most people don't even know what a child with measles looks like because of the power of vaccination. Well, this vaccine works even better than the measles vaccine. So why just the types on the vaccine? This HPV 16 and 18, and as Dr. Ari mentioned, the 6 and 11 is against Watts, because that 16 and 18 HPV type cause 70% of the cervical cancer cases that we see. So after that data was out and there was approval by agencies for the use of the vaccine, we moved on to having demonstration projects, but going to the community to test the vaccine and see the next level of effectiveness, which asks, even when something works, when you give it in program routinely, without that close follow-up in research, will people use it? Will they use it well enough that it can protect them? And the data, which is now published in peer-reviewed journals, shows that they've been highly effective in protection. So we heard from Australia data, the immediate first sign we saw was a complete drop in genital warts. Genital warts, for anybody who's had them, they're horrible. You don't want them. And you might not even wish them on your enemy, though they'll not kill you like cervical cancer will. But the first sign that that vaccine worked on a community level was this huge drop in genital warts. Then we continue to see now effect on HPV infection in those populations and in the countries that did early rollout. That was Australia, Norway, and the Scandinavia countries and Canada. Some more recent publication in Canada has given us very encouraging data. And what they've been able to show in that publication is that where coverage is over 50% of the population, so you vaccinate more than 50% on your girls, that the number of events of this vaccine type, HPV, that it drops over 60%. That's actually really good news. Now, the thing about infectious agents, remember that if you stop this person from getting that infection, it means they cannot infect the next person, right? So all these drops are really important. That 60 may not sound that big, but remember that number will not infect the next person. So over time, you cumulatively can have really big impacts on disease. And the world is now talking about elimination of cervical cancer. The question for us in Africa is, can we use these interventions to have the same impact for our populations? The next question was on safety. Is it safe? And I think many of you may have had, I think a lot of media reports, maybe online stories that may imply or question the safety of the vaccine. So if you look online, you find that there's been over 270 million doses of vaccine that have been given on program. And 84 countries already have this vaccine as part of their national program. I personally have run cohorts where we have vaccinated people at my clinical trial site. And we vaccinated girls aged 9 to 26. We also vaccinated HIV-infected children. And the biggest side effect was pain on the injection site, pain and swelling. Actually, one of the boys refused to come back. But the pain and the swelling is gone within 3 days for most of the individuals. There is within the World Health Organization, where our colleague works, a global advisory committee on vaccine safety. And that committee investigates every single report that comes to them that questions whether or not this person who got vaccinated and what the experience is that from the vaccine. And they have a panel of independent reviewers who are not related to industry to really investigate this question. And they have not found a relationship with the majority of the questions that have come up with the vaccine. In my country recently, we had a letter, but the people who were against the vaccine were talking about issues of morality and chastity. And I think those are issues we must leave to individuals. My take is those women I see bleeding and dying from cervical cancer, now that we have an effective vaccine to protect the next generation of women, we will be failing grossly to leave them exposed to infection when we have something that's so effective in protecting them.
Thank you so much, Dr. Mugo, for that background on safety, effectiveness, and efficacy as well. So most of the time, journalists want to ask, where has this been done? Is this just about Europe, Africa? Is there anything that we've done? How do we know it's going to work the same in our context? And we have on our panel countries that have implemented this vaccine on a national level. And we're going to start with Uganda, that has been vaccinating using HPV vaccine for many years, to give us an overview of HPV vaccination in Uganda. And Dr. Immaculate is coming from the Uganda Expanded Program for Immunization, and she is going to give us the Uganda story of what has been going on as far as HPV vaccination is concerned.
Thank you. So Uganda introduced the HPV vaccine in 2015. And at the beginning, we were targeting girls. We began with the demonstration project in 2008. And lessons drawn from the demonstration project is what we used to introduce the vaccine nationwide in 2015. So we've learned several lessons along the introduction, and one of the justification for introduction of the vaccine, as we have seen, is the burden of cervical cancer in the country that was easy to convince the politicians and the mothers, and everyone had already experienced the burden of cancer in the country. So it was easy to introduce the vaccine. The challenge with HPV introduction is that it's targeting children outside the traditional target group for routine immunization, which is the infants. And this is where we needed strong stakeholder engagement, where most of the girls are reached in the schools, and engagement of the education sector. It is time for the African countries to strengthen school health programs. It's time for countries to train the media who communicate to the public every day and every minute, engage them and get buy-in, and get health media experts that can communicate competently to and address emerging issues in the public. We also learned that it is very important also to countries. It's time for us to strengthen our programs, looking at now it's no longer the baby, the under 1 year. It's time now to look at the adolescent and look at this child from birth, looking at the continuum of life, the life cycle, starting immunizing a child at birth up to 9 months, and now going to HPV and other vaccines and other child survival interventions. Countries like Uganda are also struggling with maternal mortality, and as we struggle to solve the maternal mortality that is associated with birth, cervical cancer also is a new challenge that might interfere with achieving that goal. So cervical cancer is the second cause of cancer in women, second to breast cancer, and so it's up to us as African countries to take on this new technology and protect the next generation from this deadly disease. We have not suffered significantly the issue of safety, because the burden of disease in Uganda was very evident. And we found that the schools actually are very organized. Children are in one place. It's up to us to provide information to the teachers, to the parents, and vaccinate these girls. I think that's what I have to say.
Okay, so thank you so much, Dr. Immaculate. And we're going to make sure that we add a Francophone flavor to our discussion. We have the Anglophone. So we are going to hear from my brother from Senegal. He's going to give us an overview from the Senegal experience, and he's going to speak French, and he needs an interpreter.
Translate.
So he's going to tell us a quick overview about, implementing HPV vaccination in Senegal. Dr. Badien.
Thank you so much. I think that all the journalists who are here understand French because they are bilingual. Donc, je vais parler en français. Donc,
Oui.
pour partager l'expérience du Sénégal. Et comme vous venez de le dire, le cancer du col de l'utérus est un problème de santé publique. Et le Sénégal fait partie des pays les plus touchés en Afrique de l'Ouest, où le cancer du col, c'est le premier cancer gynécologique, mais aussi ça représente 30% des causes de décès par cancer. Et la bonne nouvelle, c'est que c'est un cancer qu'on peut prévenir par la vaccination. Dans les stratégies de lutte contre ce cancer, il y a quand même 3 niveaux de prévention. Il y a la prévention primaire qui consiste à la vaccination, la prévention secondaire qui est le dépistage et le traitement des lésions précancéreuses, et la prévention tertiaire, qui est la prise en charge des cas et les soins palliatifs. Maintenant, si on regarde ces trois stratégies, on voit nettement que la vaccination est la stratégie qui est la plus adaptée et qui est la plus facile à mettre en œuvre dans nos pays à revenus faibles ou intermédiaires. C'est pourquoi nous avons décidé d'introduire ce vaccin dans le programme. Il faut rappeler que le vaccin était déjà disponible au Sénégal depuis 2008, mais c'était dans le secteur privé et c'était vendu à un prix très élevé qui n'était pas à la portée des populations. Donc, il y a eu des organisations de la société civile qui sont venues faire un plaidoyer au niveau du ministre de la Santé pour lui demander de voir les voies et moyens de rendre ce vaccin accessible à l'ensemble de la population. Et c'est en ce moment que le ministre nous a saisis, nous qui sommes les techniciens en termes de vaccination, pour nous demander de voir les voies et moyens d'introduire ce vaccin dans le programme. Après revue, on s'est rendu compte qu'il n'y avait que deux possibilités. C'est que la première possibilité, c'est que l'État avait les moyens d'acheter les vaccins. Si l'État a les moyens d'acheter les vaccins, il achète les vaccins, on le met dans le programme. Ou bien, on sollicite l'appui de Gavi, comme on est un pays éligible au soutien de Gavi, pour nous accompagner dans cette introduction. Et finalement, c'est la deuxième option qui a été retenue, et on s'est tourné vers Gavi. Mais Gavi avait ses conditions. Donc la première condition, c'était qu'il fallait que le pays fasse la preuve de sa capacité à intégrer ce vaccin dans son programme, avec au moins des couvertures supérieures ou égales à 70% pour les districts qui seront choisis. Deuxièmement, il faut que la vaccination s'intègre dans un plan intégré de lutte contre le cancer. Donc, fort de cela, nous avons fait la proposition et nous avons soumis à Gavi pour une phase de démonstration dans 2 districts, donc en 2013, et on a été accepté. Et c'est en 2014 qu'on a commencé la phase de démonstration dans 2 districts avec des résultats très probants en termes de couverture vaccinale, parce que dans tous les 2 districts, les couvertures étaient supérieures à plus de 90%. Et on a fait une phase d'extension de 2 ans jusqu'en 2017 en ajoutant un 3e district. Et sur l'ensemble des filles qui ont été vaccinées, dont le nombre s'élève à plus de 50 000, nous n'avons eu aucun cas d'effet secondaire majeur. Et fort de cela, nous avons encore élaboré le plan d'introduction pour mettre à l'échelle cette intervention. Et nous avons été approuvés pour mettre à l'échelle la vaccination en 2017. Et ça a été reporté du fait de la tension sur les vaccins. Et c'est à partir d'octobre 2018 que le vaccin a été introduit dans le PEP de routine. Et actuellement, le vaccin est disponible sur l'ensemble du pays au niveau de toutes les structures sanitaires. Maintenant, ce qu'on cible, c'est les filles âgées de 9 ans. Et comme la majorité de ces filles sont à l'école, donc il y a des stratégies aussi pour aller les vacciner à l'école. Et ceux qui ne sont pas à l'école aussi, il y a des stratégies communautaires pour les vacciner. C'est vrai qu'après l'introduction, on a eu quelques difficultés par rapport à la communication, mais je pense que tout ça là, c'est derrière nous. Et actuellement, les couvertures sont à plus de 90% pour la première dose du vaccin. Et je pense que d'ici 2-3 mois, les couvertures de la deuxième dose vont suivre, du fait qu'il y a juste un décalage de 6 mois entre la première et la deuxième dose. Donc actuellement, le Sénégal est le premier pays d'Afrique de l'Ouest à avoir introduit ce vaccin dans son programme de vaccination de routine.
Merci beaucoup. So I'm going to have Fiona do a quick translation, briefly, of what has been said, to make sure that we have the information everyone has heard. That it's very important, like Dr. Badien has mentioned. Senegal is the first West African country to have started the national rollout. And it was very important to hear from them, and we're hoping that more West African countries are going to take up. We've seen a lot of national programs starting in the southern part of Africa, but we need more in the western parts of Africa as well. So Fiona is going to give us a quick recap of what has been shared by Dr. Badien.
Okay. Thank you very much, Sharon. So Dr. Badian from Senegal. He's the EPI manager, the manager for the immunization program in Senegal. And he told us that cervical cancer is the leading gynecological cancer in Senegal, accounting for 30% of cancers in Senegal. And the country in 2008, the Minister of Health did demand that they wanted, because they knew the impact of the HPV vaccination on reducing cervical cancer, they wanted to have this vaccine introduced to their girls in the whole country as soon as possible. And they said, we have two options. Either the country will actually go ahead and buy the vaccine and we vaccinate the girls ourselves using our funds, or because they're a country that is eligible for Gavi Funding, Gavi the Vaccine Alliance that does funding for most low-income countries for vaccines, they will apply to Gavi for funding to request that they introduce this vaccine into their country. But when they applied to Gavi, Gavi told them, when they contacted Gavi, Gavi told them that they had to meet some criteria, and the first criteria was that they needed to demonstrate that as a country they can actually vaccinate innocent girls, and they told them they needed to do the demonstration program that I mentioned in 2 districts. So in 2014, they did the demonstration program, and that waited to roll out into a national program. In 2017, they added a 3rd district and totally vaccinated 50,000 girls. So, and they demonstrated that they were able to reach girls of this target age group. In 2018, last year in October, they were able to introduce the vaccine into their national program. And the introduction was a bit difficult because they had communication issues that arose in the country. But again, he's very happy and proud that Senegal has been the first West African country to introduce the HPV vaccine into their routine immunization program.
Okay, so thank you so much. What we want to have now, after hearing the various presentations that have been done by the able panelists that I have with me, giving us, a range, what is the burden, what are the interventions, and we narrowed down to HPV vaccination. As we mentioned at the beginning, the strategies we have is vaccination, screening, and early diagnosis and treatment of cervical cancer. This will lead us to elimination of cervical cancer. This is not a one-way platform where we are just giving you information. It's an exchange of information. So for the next few minutes, we want to hear from you through comments, through questions, and the panel can expand further on something that you want expanded. So we want to invite questions from the media. We know that questions and comments, exchange of information. So we know that the media is one of the main channels that we need for the successful implementation of these HPV vaccine on our continent. Without the media having the right information, without the media being engaged, without the media disseminating the information, we know that most of the people are not going to know, and the uptake is going to be affected. So today we also want to hear from you, to get your questions, your comments are welcome, so that the panel can be able to answer whatever it is that we have. If you give us a question that we do not have, we will still find it for you and be able to post. We have your names, we have your emails, we have your numbers, we'll be able to give you, but I'm sure they are more than able to answer the questions that we'll bring. So we'll invite some questions from the floor. I can already see one. Please go ahead. They can't hear. A bit louder.
Thank you so much. My name is Musa Melesa from Ethiopian News Agency. My first question is, what's expected from the today's summit? What will be the outcomes of the summit? The second question will be about 12% of only 12% in the vaccination distribution in Africa. Why that has been the case? What are the challenges? Is there any global vaccine shortage or price of the vaccine? And in terms related to vaccine, what are the government expected to do in terms of vaccine distribution? International organizations like WHO, other organizations will help in terms of vaccine distribution in Africa. The next question is how this HPV virus is serious in Africa. If you can give us figures about how many people are affected by this virus, specifically in Africa. And beside vaccine, is there any treatments that can cure this HPV virus? And also we talk about only girls, but HPV virus also, does affect also men? So if that is the case, how the men are going to be treated? Is there any mechanism that I don't see any Ethiopian representative in the press conference, but from anyone who can give us an Ethiopian experience about HPV vaccine project? Yes, thank you so much.
Thank you.
My name is Ingo Tomwanza. I am from Zambia Embassy. My first question is directed to Dr. Kapambwe. I just wanted to find out from you how Zambia has managed to deal with myths that surround the vaccination of HPV. And then I also wanted to find out from you where the funding for this is coming from. Do we have local resources for the vaccination? The other question is that we have seen that in Zambia, there have been like some active stakeholder involvement. We've seen the First Lady being one of those that the ministry, I think, has engaged. I just wanted to find out whether this has been extended to also traditional leaders, because we know that some of these myths that surround the vaccination are mainly in rural areas. And then from the World Bank, I just wanted to find out from you generally how you think Zambia has performed. Yeah.
What's the last question?
Performed. Yeah, I think that would be an independent thing from the World Bank. Thank you.
I think we get the last question. Not the last question, for this one.
All right, thank you. My name is David from Capital Newspaper. I do have two questions. First question is, we need to hear the success story from African countries, leaving alone the stories of Australia and Canada, because that's a different context. And I think there are 14 African countries already started in this process. And a number of African countries are left to start from, vaccination. So what do you think is a challenge that most African countries are not involved with to start the vaccination? And it's better to just share a success story so far. Thank you.
So I will start with the questions that have come from the floor, then I will distribute the ones that have come from online. So I think the question, Dr. Fiona, there are three questions that are almost the same. Why are we at 12% as Africa? That came from the Ethiopian news agency and has also come from Capital. What is happening? And for the question on what must governments do, I think the people here that are representing the various governments is Kenya, Senegal, Zambia, and Uganda will be able to make a comment. But first, I'm going to give Dr. Fiona to be able to comment on why is Africa lagging behind. Do we have success stories?
Thank you very much. Why is Africa lagging behind? The major reason really is because we have competing priorities in the region. We still have very many diseases to deal with some of our biggest problems being TB, HIV. We are still struggling with malaria. We are still struggling with outbreaks, Ebola, Lassa fever, cholera, typhoid. We still get malaria outbreaks. We have all these that we are still struggling with, which the developed world has gotten rid of. So because of the many competing priorities we are dealing with, I'll give you an example. Sierra Leone and Liberia were set to begin their HPV vaccinations demonstration programs in 2014. Then we had the Ebola outbreak. And these countries could not do anything because everything was shut down, even the immunization programs for polio, for tetanus, everything was closed down because of the Ebola outbreak. This is the same thing we're having in DRC right now. Such a huge country with such a huge population gets a measles outbreak, started with a cholera outbreak. In the middle of the cholera outbreak, gets an Ebola outbreak. In the middle of the Ebola outbreak, gets a measles outbreak. How does such a country start introducing an HPV vaccine? They also have a polio outbreak. So all the efforts in that country are on managing these outbreaks. We were in Zimbabwe. Zimbabwe started with a cholera outbreak. In the middle of the cholera outbreak, gets a typhoid outbreak, then is hit by cyclone, he dies. And then the cyclone just disrupts everything. We start vaccinating now to prevent cholera spread, to prevent typhoid spread. So that on top of that, we have to continue vaccinating to ensure children don't get polio, to ensure they don't get whooping cough, to ensure they don't get diarrhea from rotavirus. So there are so many competing priorities on our continent that we still have to sort out as we now start ramping up this HPV vaccination. But we are trying. In the next few years, we hope that many more countries will introduce. We still have malnutrition. Ethiopia has a lot of malnutrition. Are you aware that we still have many undernourished children, and we are fighting with hunger and famine and drought, and we have so many problems. So, but this is, on top of that, we have cervical cancer and many other cancers that we are trying to fight, which the other world has dealt with. They don't have malaria anymore. They are not fighting TB and HIV as we are doing. Cholera is a story of the past. Typhoid was eliminated. They hear stories, they see them on TV, that they're in Africa. But we still have so many problems to deal with. On top of that, we are trying to ensure that we deal with this. The other one was the Zambia coverage.
Yes, how was Zambia done?
Zambia, from a WHO perspective, your country has done very well. You said you're from the Zambian embassy, because we work very hard as the World Health Organization with other partners to ensure that we prepare these countries. HPV vaccine is an expensive vaccine, and we cannot afford to lose any single dose. We cannot afford for the country not to take up the vaccine and it expires in the country because it's quite an expensive vaccine. So we invest heavily in preparing the country together with the Ministry of Health. This was a country that was quite committed to with high political commitment. The health workers were very committed. The Ministry of Health was committed to introduce this vaccine. So Zambia has come up with over 90% coverage. And when we mention coverage, we mean the 90% of the girls that were supposed to receive this vaccine did receive it. And this was the first dose of the vaccine. We are waiting to hear what happens to the second dose, because that is where we sometimes get problems when the girls drop out. So Zambia went for 14-year-old girls, and they did get them. Thank you.
So the next question is, what should our governments do, Dr. Mugo, to ensure that we get HPV numbers, vaccination percentage up on this continent?
What should our governments do? The success of programs, I think we had a really good session today where my colleagues here from national programs presented. And some of the things that were clear is where you asked about Africa success stories. The Africa success stories were tied to government commitment, political commitment to the delivery of the vaccine. I think we've just had Senegal. Right before even WHO or Gavi spoke about it, they intended to have the vaccine. The Zambia success story has been a continuous story of wanting to really impact on cervical cancer prevention. And where that doesn't happen in a country, the program doesn't even start. That's why you hear that there's so many countries who have not initiated the vaccination program. So the commitment has to start from the national level. One of the things I think I've often observed, I'm a long-term civil servant, so I don't know whether it's my bias, but this is my observation. If you start something and it's only done in the private sector, in Africa at least, and it's not in public sector, it doesn't impact population, because most of our people still seek services from public. And the success of the EPI programs comes from the government delivery of the EPI program. And then the other thing was education. We heard today about educating the healthcare provider, partnership with the media, I think, and I'm going to pass this on to my colleagues who are running EPI programs because they will have the best answers.
Senegal.
Bon, je pense que, comme elle l'a dit, ce que nos gouvernements doivent faire, c'est que tout part de la volonté politique. Donc, je pense que c'est un élément très important. Mais il faut aussi que les techniciens puissent donner assez d'arguments, des arguments convaincants, pour que le niveau politique puisse quand même adhérer à la cause et décider d'introduire ce vaccin-là. Parce que comme on l'a dit, hein, donc, les preuves sont là que le cancer du col est un problème de santé publique majeur et qu'il faut agir rapidement pour contrôler ce cancer-là. Maintenant, par rapport à la mise en œuvre, je pense, comme je l'ai dit, il y a deux options. Il y a les pays qui ont des revenus élevés, donc qui ne sont pas éligibles à l'appui de Gavi. Il faudrait convaincre ces pays-là, convaincre le gouvernement pour qu'ils puissent mettre de l'argent pour acheter les vaccins. Maintenant, pour les pays qui sont éligibles à Gavi, c'est le système du cofinancement. Donc, il y a une part que l'État doit donner et l'autre part doit être donnée par Gavi. Donc, c'est le cas du Sénégal où l'État a accepté de financer la contrepartie que Gavi demande pour que ce vaccin-là soit mis à la disposition des populations. Et il faut aussi, je pense, l'implication des organisations de la société civile. Je pense que c'est très important parce que si la demande vient de la population, c'est un élément de plus pour convaincre les décideurs. Parce que les décideurs, c'est les politiciens, en fait, ils n'iront jamais à l'encontre de la volonté populaire. Donc s'il est clair que la demande vient de la population, ça peut être un élément très déterminant dans la décision que vont prendre les États. Merci.
Merci beaucoup. Do you want to say something?
On what he said, yes.
Okay, just quickly on what Dr. Badian said. He also mentioned the political will, that political will is very important in the country, and then the advocacy and making a case and argument and justification for the vaccine. And where there's the will, there's a way. And he had also mentioned how the country had two options, to either pay or go for Gavi funding. And even when Gavi gives you the vaccines, the country has to co-finance. You have to pay your part. Gavi does not pay 100% of the vaccine. So Gavi informed them the vaccine was available if they are ready to co-finance. And the country was very ready to co-finance. And they also had population demand because the population was asking for it.
Yeah, thank you for the question. What African governments need to do? One, African countries, although we say we are low-income countries, we still have so much potential within our countries in terms of expertise. We have academia, we have advocacy, we have parliaments, and these are the resources that African countries have, and also that access the global platforms to negotiate. So countries, as African countries, we need to partner with the academia and generate local evidence that is going to convince the politicians, our parliaments, and build a case for the introductions of these vaccines. And also we have local resources within countries. We have WHO within countries. We have the Gavi support that for the start will introduce the vaccine through the co-financing arrangement, but eventually countries have to take on the responsibility to sustain that resource. And as the bigger region, through maybe the African Union or through regional groups like the East African Community, if we unite, we have better negotiation power in terms of negotiating for costs and stabilizing the market towards the traditional costs. So African countries, we still have platforms of committing as a region to protect our populations. WHO recommends a comprehensive package because African countries, we have low resources for early diagnostics. The health-seeking behavior, our systems are not strong enough to pick cervical cancer at the point where it can be cured. So WHO recommends investing in other interventions, and vaccination is one of them, in addition to others. Radiotherapy and chemotherapy is also expensive. We need to trade off what is the investment in primary prevention vis-a-vis the tertiary prevention through radiotherapy and other rehabilitative services. So Africa, we need to be the case and protect our girls, because we still have the 75% of the girls in the region that have not introduced the vaccine. Thank you.
Okay. I wanted to add a comment and say, while Gavi is funding us for one age cohort, the 9 to 14-year-olds, and right now countries are choosing, like Zambia, 14-year-olds, my country, 10-year-olds. For real impact, we need to do the catch-up. In countries where they've seen quick impact, in Scandinavia and Australia, they did catch up to the age of 26. So I think countries really need to add investments. And countries need to invest in screening, as we've heard, for precancerous lesions for women, so that the vaccine programs work hand in hand with a prevention program for women in Africa. Then we can reach the goal of elimination a lot faster, and we can bury a lot fewer women. The data on deaths of women in Africa is 270,000 every year, right? But then 80% is in sub-Saharan Africa. And I'm always asking people, please do the math. 300,000, 375 days a year, how many are those? Every single day. We're putting women in coffins who don't need to be there.
So I'm going to quickly comment before I go to some of the online questions that are coming on. I was asked a question about HPV vaccination. How did Zambia overcome the myths and misconceptions and having active stakeholder engagement? Have we engaged the traditional leaders? One of the things that has helped a lot in HPV vaccination in our country was engagement both from the bottom and from the top. Like you have rightly said, the Office of the First Lady in Zambia has been actively involved in issues of cervical cancer, in issues of cancer in general, and even ensuring that interviews are given, going over and showing people what is done, where we are screening, where treatment is being given. Other than the First Lady's office, we have actively engaged the media, and not just the media at national level, even at sub-national level. We have what are known as community radio stations. So before embarking on the national rollout, we made sure that we brought all the journalists from the rural areas, at least one from each of the community radio stations, and we spent 2 days discussing HPV vaccination before we rolled out. And they started writing stories about cervical cancer. We took them over to the hospital. We took them over to the screening programs so that they could see the various interventions that are taking place in the country. We also made sure we have what is known as the House of Chiefs, where we have the traditional chiefs representation for the country. So we went as people from the EPI, from the cancer control team, to talk to these chiefs. So we were given a slot to explain to the chiefs the burden of cervical cancer in the country, the interventions, what is government doing, and also what are we asking them to help us with. These are the chiefs who know the young girls who don't go to school in the villages. They are also, influential people at rural area level and can be able to influence how the vaccine is viewed. In that meeting, we had 3 chiefs, 2 male chiefs, and 1 female chief who came up and vowed to be champions for cancer of the cervix. So those are some of the initiatives that have taken place, and making sure that if you're traditional leaders on national levels, we have had national meetings which we've called Indabas, with the religious leaders as well as the traditional leaders. We brought over 80% of all traditional chiefs to discuss health in general, and part of that discussion were the issues of cancer of the cervix. So a buy-in right from the rural area, right from the chiefs who are in charge of these rural areas have been very, very helpful. That we've seen that acceptability as we started national rollout has really not been a problem, because the media has covered us with positive stories of what is happening and why the girls need to be vaccinated. So we've had a very good response as a nation in terms of HPV vaccination. And Ethiopia wanted to know the Ethiopia experience. I'm going to give WHO to give that. I'm going to distribute the questions from online as soon as she gives me something.
Okay, thank you. So Ethiopia is one of those countries that also had a very strong political will. Your Minister of Health really, really wanted the HPV vaccine introduced at all costs. Just like Senegal, he was ready to find funds so the country could fund its own HPV vaccine. But at the same time, just like in Senegal, Ethiopia was a Gavi eligible country, applied to Gavi for funding, and Gavi gave the same condition that you needed 2 years experience of the demonstration program to show that you're able to vaccinate girls of this age before you can be allowed to go nationally to introduce this vaccine. So in 2015, June, Ethiopia introduced the HPV vaccine in Oromia and Tigray regions to adolescent girls. And this was also learning by doing to see if this can be done, and actually achieved very high coverage in the 90s. Over 90% of the eligible girls were gotten. After this, the country became eligible to apply for funding to introduce the vaccine nationally, and that is what happened. And in 2018, last year in December, here in Addis, there was the launch for the vaccine to be introduced nationally. We had some issues in some regions, like the Somalia region and the Afar region, and SSNP had polio outbreaks, so we had polio campaigns there. And then we had some delays in those regions, but they have also now introduced. You have regions that have many out-of-school girls as opposed to girls who are in school. For example, in Afar region, we have partners like Jepaigo that took special initiatives to go to Afar region and look for these girls who are out of school and ensure that they are vaccinated.
So I'm going to quickly go to the online questions that have come in. The first question, which is going to Dr. Mugo, is most African girls' sexual debut is before 14 years. And you were telling us that we should be vaccinating 9 to 14 who are not yet most likely proxy sexually active. The other question that is coming is, can this vaccine be given to infants during the childhood vaccine? Why are we not giving it to the children? Easier for implementation. What is the science? To Dr. Immaculate, cervical cancer poses a challenge to maternal mortality. The journalist wants you to expand further. What did you mean? And Dr. Immaculate again, it's about uptake of vaccination. Last year, his study found that girls were missing the second dose of the vaccine in Uganda. Why do you think it is so, and what has the country done to address this issue? The other question is going to go to WHO. How prepared are countries technically and financially to deal with the issues of cervical cancer burden and especially HPV vaccination? The other question also is, what has been the response of African governments to investing in mass vaccinations of HPV, and how have we involved the private sector? So I'm going to go to Dr. Mugo, then I'll come to Dr. Immaculate, and then Dr. Fiona will come in.
Thank you for those questions. Some of those questions have actually been asked by scientists themselves. So people have postulated, perhaps we could start, and it would be so much easier to, combine this vaccination with the infants. So there are several reasons not to start with infants. One, we actually don't have data. We don't have data on safety. We don't have data on durability. So if we started with infants now, by the time they get infected, the majority of people with HPV, with cervical cancer, are around the age of 40 and up, and with lesions 30, we wouldn't see impact. We'd put an investment early, and we wouldn't see effect. And that's why you see countries like Zambia, when they have an age of 9 to 14, choose the 14-year-old, so they're not losing a cohort effect. More challenging to start with adolescent, but faster impact. We don't have data on infants, and perhaps along the way, science will give us data when people are adequately, vaccinated. That may happen, or maybe we'll do better for adolescents and have a fuller program for adolescents. So the HPV vaccination may be the beginning of a real health program for the adolescent girl and boy. The issue of sexual debut, there isn't a sexual debut for Africa because Africa is so diverse, as you know. So for example, in my country, Kenya, the national survey shows sexual debut at around the age of 17. I know very often, we see reports when things go wrong, when we find a 9-year-old who gave birth, or a 10-year-old, and we're like, these children are all having sex, because we highlight those. But actually, most of them are not having sex. So it's more around the age of 17. Then there was a question about the older woman. Can she be vaccinated if she's sexually active? And as I told you, the primary cohorts that proved that the vaccine worked was actually amongst young women and girls from the age of 15 to 26 with no more than 4 lifetime sexual partners. So the key thing about the vaccine is that if you've had previous exposure, it will not protect you. But remember, it protects you from more than one HPV type, and not everybody has been in contact with the HPV infection. So for the one you haven't been in contact with, you'll be protected. So even when you're sexually active previously, you can still get vaccinated. On a national health public level, the governments have to ask themselves, where can we best place our resources for the best results? And that would be on the pre-section, not meaning that for the others it doesn't work. There have been studies done for women up to the age of 45. So the effect is not as good because when your immune system is young, you also respond better to vaccines, but you still have benefit. There are even studies which have shown people who have early lesions, maybe you got it from HPV 18 and you don't have HPV 16. Then going forward, you're protected from the other HPV type. And then the other one was HIV infected. Yes. And actually the study I did at my clinical trial site was amongst adolescent girls and boys, so both gender, who were HIV infected. And there have been other studies, even on older women in South Africa, and it's shown to be effective. They don't respond quite as well. That's why for people older than 15 years, and then we heard HIV infected, we want them to get the 3 doses of vaccine. I think that's it. Yes. Thank you.
I'm going to go to Immaculate. Okay. Thank you for the question. What I meant by the challenge of maternal mortality is that we are focusing on reducing maternal mortality. But if we don't handle the challenge of cancer of the cervix, the mother will survive that, but there's something else waiting. And that also causes health risk and inequity due to having a cervix. So this vaccine will help us also address the health challenge posed beyond that. Then on the issue of the low uptake of the second dose in Uganda, why? So we conducted a post-introduction evaluation and the causes of the low uptake of the second dose. One was the weak leadership and management at the different levels, and lack of engagement with the education sector. And what we have done with that is we've picked the lessons learned from that post-introduction evaluation by engaging stakeholders at the national level and going down to the districts and doing the same thing, engaging the leadership, which we said was weak, and involving the teachers to enhance linkage with the school and the service points. So that's what we have done, and we continue to supervise and learn lessons and strengthen our routine immunization program and school health program.
Okay, so thank you. One of the questions was how prepared are the countries technically and financially for HPV introduction or cervical cancer, management of cervical cancer. By the way, not all countries, we have criteria to also allow countries to introduce a new vaccine. So not all countries do qualify to introduce a new vaccine because some of them are still struggling even with the traditional vaccines they have. So we have some criteria, for example, if the country has not reached 70% of their babies with the third dose of this, what we call a pentavalent vaccine, which prevents whooping cough, diphtheria, tetanus, and hepatitis B and Haemophilus influenza. There's that dose, that vaccine that children get and get high fevers. The 3 doses they get and they get high fevers. If we have a country that has not reached 70% of their children with that third dose, we tell them that please work very hard on ensuring that it shows that the immunization program is not yet strong enough to handle another vaccine. If we bring in a new vaccine, it will disrupt even the little they have. So they have to first focus on growing the immunization program to a better level before they disrupt it with a new vaccine, because a new vaccine is a whole new process. If you don't know, vaccines are kept in fridges. They are transported at a certain temperature. The health worker must handle it in a certain way so that they don't hit it and kill it. The active ingredient doesn't die. They are vaccinated in a certain way. So if the country is not strong enough to do that already, we only start by supporting it to get to that level. Then now they can introduce a new vaccine. So some are not yet at that level, so some are already ready to introduce the vaccine, but how prepared are they? We have several partners who work in HPV. We have WHO, we have UNICEF, we have CDC, we have JPIGO, we have so many partners, PATH, so many that have expertise in the introduction of this vaccine. Some countries are virgin. They did not do demonstration programs, so they don't have any experience. We are there to support them. We are committed, partners are committed to support them. We get into that country and prepare the country. Financially, it's the same as response of African governments on funding this and involvement of the private sector. We have what we call the Addis Declaration on Immunization. In 2017, the heads of state of the African Union heads here in Addis Ababa ratified what we call the Addis Declaration on Immunization, where they signed a document and committed themselves to 10 commitments to improve immunization financing in their own countries, that the governments would finance this. Countries right now, these were presidents, heads of state, not that they were ministers or anybody, they were heads of state. A few countries have taken this ahead to increase funding for immunization, for example, Uganda being one of those countries. After the president ratified this, they went ahead to have a law and an immunization act and put together an immunization pool, a pot of funds that are dedicated to immunization to increase funding. Some other few governments have done that to put special funds aside for immunization. We're encouraging more countries to do that, involving the private sector for as long as they can mobilize funds locally so that we reduce on the donor dependence. That is what we are all working towards.
So I'm just looking, there's one question, probably can pick up this one. If vaccination is done for girls up to the age of 14, what is administered for girls 15 and above? Is that where secondary prevention comes in? So we have talked about the different strategies of controlling and finally eliminating cancer of the cervix. HPV vaccination being one of them. And from the call to action and what we're looking at ensuring that 90% of the girls receive the HPV vaccine by the age of 15. And then we're also looking at 70% of the women receiving screening by 35 years old, and also ensuring that 90% of women who are found with early lesions for cervical cancer and indeed cancer of the cervix itself are treated adequately. So what we're looking at, when you see that those who are already sexually exposed, screening comes in. And screening recommendation, we're looking at women who are at high risk of getting HPV and indeed developing cancer of the cervix. So we have women who are living with HIV, as was mentioned, who are 4 to 5, even up to 10 times more likely to develop cancer of the cervix. We're looking at women 30 to 49, some countries have 25 to 49, who are also going to have what we call a persistent HPV infection and can end up with cancer of the cervix as well. And those who are the ones that we want to target to ensure that they are screened. So if someone is not vaccinated, even if they are vaccinated, like Dr. Mogo mentioned, that's 80%. So screening and vaccination go hand in hand. And if we find that some of the people are not screened and they end up with cancer of the cervix, they slip through the cracks, we ensure that they get treatment. That is why advocating for treatment, early diagnosis and treatment, to have better outcomes for cancer of the cervix. So yes, you are right. For women who are older, already sexually exposed, then we go into secondary prevention, which is also known as cervical cancer screening. We still don't have very good coverage in terms of nations having full-fledged cervical cancer screening programs on this continent, and that is one area that we're looking at to ensure that an HPV testing is done for these women, and they can also be prevented from getting cancer of the cervix. If we find early lesions, then we treat them for those early lesions and they do not end up having cancer of the cervix in the future. So as I look at these questions, I think we have adequately answered your questions. Hopefully. Okay, so what is expected from the summit? So I'm going to give a brief of what is. So this summit has brought together different African countries. So we've brought together English-speaking countries, French-speaking countries, and one of the major reasons is for us to be able to share information. So we want to share our experiences, we want to share our best practices, we want to find solutions to some of the challenges that we've been facing, particularly with HPV vaccination. Where Zambia might be failing in a certain area, you can find that another country is doing far much better. It's information exchange. It's also having new updates scientifically. We've had scientists coming in and showing us the studies that are going on and what type of evidence has been involved and how we can be able to inform the masses much better. So this is Africa coming together. We are the ones with a high burden. We want to come together and exchange ideas. We want to come together and ensure that when we go to lobby to our government, we have up-to-date scientific information. We can be able to have good buy-ins. We want to find solutions to some of the challenges we're facing as different countries on this continent. So this summit is basically bringing us together and sharing information and experiences and ensuring that we come up with solutions that are suited for this nation, for this continent, that can we can help each other in the elimination of cancer of the cervix. So there's a question, and I know that Fiona, I think you deal with that. There's been questions about cost of vaccines. How much are these vaccines? Are they affordable? Can these African countries be able to afford? And I think she has answered to some of the issues of being Gavi eligible. Those who are not Gavi eligible will have to buy this vaccine. But I'll let Fiona comment before we wind up.
Thanks again, Sharon. So the HPV vaccine, we have different costs. Why do we have different costs? Depending on your bargaining power and who you are. So for us, Gavi eligible countries, where most of our countries lie, the low income countries, Gavi got us a Gavi price of $4.50 per vaccine, that per dose. For the 2 doses, that is $9 per dose. However, if you are not Gavi eligible, like some countries like South Africa, countries like Botswana, countries like Gabon, those countries that do not get their vaccines from Gavi, we have tried as much as possible to try and negotiate this for these middle-income countries to receive the Gavi price, and we are almost there. But in the meantime, they are all getting their vaccines from different sources, some straight from the manufacturers, some through middlemen. So if you go to a private clinic, the vaccine could cost you $20, or could cost you $100, or could cost you $200. So it depends on where you go. It's just like going to a private hospital for surgery. You could have a cesarean section for 10,000 birr, you could have it for 1,000 birr, you could have it for 1 million, so it depends on where you go. But for the countries that have it in their national program, like South Africa or Botswana, I know that Botswana is getting their dose at about $23 per dose, but we are still trying to negotiate for these countries which are middle income to get this vaccine at the Gavi price. So when we say a country gets it, if you can get it at $100 per dose, for 2 doses you're talking of $200. So it's not a cheap vaccine. So we still thank Gavi, the fact that we are still Gavi eligible, and should use this opportunity to get this vaccine at $9 for a fully immunized girl as early as possible, so that we can vaccinate as many girls as possible, because we reach a point and also transition out of Gavi. The more your economy grows, the more you no longer need support, and the more you need to pay for your vaccines. So we need to utilize the opportunity we have as soon as we can.
Okay, and finally, you get the cost of the vaccine. There's also the issue of the cost of the delivery system, which also becomes a cost on its own. You know that we're talking about adolescent girls who do not normally go to the clinic. We have to go to the schools to find them and to get high coverage, and that's a cost. It's a cost that we're going to get a nurse to go there, and then it's also a cost, that these girls have to be put and they come into. One of the things that we have been discussing in this summit is also about ensuring strong school health programs on our continent, not just for HPV vaccines, but for other interventions for the children, for the adolescents who do not normally go to these health facilities. So governments investing in health systems is very critical for a successful implementation of HPV and other health services for school-going children is important. Also, being able to find the girls who are not in school is also a cost, and we have to find strategies of ensuring that we have strong systems of locating the girls who are not in school. So overall, we would want the vaccine as cheap as possible, because we get a cheap vaccine, we also need to look into delivery systems that we are having. So with all these remarks and all these presentations and questions, I know we've gone over time, but I hope this has been engaging enough and that you have learned a lot from what HPV vaccination is about and what this summit is all about. Is that a new question coming in? I think we need to.
No, just the names.
Okay. All right. So you're all the panel is going to introduce themselves as they would want. We'll write for you, but as you would want to be quoted. We're going to write our titles, but we're going to introduce ourselves, how we are known professionally.
I'm Dr. Nelly Mugo from the Kenya Medical Research Institute.
Dr. Ousseynou Badian, I'm the manager of the API program in national level in Senegal.
I'm Dr. Sharon Kapambwe, Assistant Director, looking into cancer prevention at the Ministry of Health in Zambia.
And I'm Dr. Fiona Atwebwe, and I'm in charge of new vaccine introductions for the African region at the World Health Organization Region Office for Africa, based in Brazzaville, Congo. Not Congo, the DRC that has Ebola. There's another Congo, not the Democratic Republic.
And I'm Dr. Immaculate Ampere. I'm a senior medical officer with Uganda's immunization program.
So we're still going to write down our names and our titles for you to be able to get them. We sincerely want to thank you that you came. Thank you to the people who've been online, who've been sending us all these questions. We're grateful for the engagement, and we know that the more the media has information, the better the outcome for our various programs, because then you'll be able to give the population the much needed information about what is happening today and what is happening as far as HPV vaccination is concerned. So thank you for coming. Thank you for your questions. For the people online, thank you for being there and sending us those questions. This is where we end this session. Have a great evening. Thank you.
Grace.
I'm not sure. Yes, I can. I have so many business cards. I never went to my office.
You did an excellent job. You were magical. Thank you. I was watching you online. Oh, you big time. Excellent work.
He owes us big bottles of champagne.
Actually,
I think what we can do when we write that one, can we photocopy that one?
okay.
Can they, Austin?
But can I give you Ethiopia from the one?
Can we have this photocopied and given out?
Okay, yeah.
Yeah, that would be much easier. We're all going to write on these papers and then they can be photocopied and people can go with it. Do they need our emails? All right, thank you. Thank you.
Your title?
Oh, my job
You haven't put your title, you've just put where you work.
You want it in America?
No, it's not yet 9 p.m. It's 19. Zambia.
Huh? You see, this summit is still going on.
You give me just half an hour.
What is it?
Half an hour.
What does he want?
We are studios tomorrow.
Oh my God.
Yeah.
Where is my... What we've done? Who's the... Austin, who's got the paper? I wrote it. Oh, someone just now. Who took the paper? Who took the paper where we were writing? Yeah. So the photocopy, he's going to photocopy and give all of you. Okay, where did I throw my hand back?
Is it the first African HPV summit or?
We've had before, but it's been a while.